We will move to the fourth case. Actually, Dr. Alaa Gad, she will present a nice case for us.
Good afternoon, everyone. I'm Alaa Gad, lecturer of clinical pathology at Qasr Al Aini, Cairo University, and I'm honored to be among my dear professors and colleagues. I'm going briefly to present and discuss an interesting case regarding congenital anemias in children. A 4-year-old boy came to our hospital complaining of severe pallor, dark color of urine, and he has a past history of admission in the ICU on the second day of birth, where he was given intravenous immunoglobulins, and there was no history of any drug intake whatsoever. He is the second child of a consanguineous marriage, and also his mother and older brother suffered the same clinical manifestations. He's on regular blood transfusion. He takes blood every 6 months. By clinical examination, we found that he has mild hepatomegaly, moderate splenomegaly with span 14 centimeter, with mandibular lymphadenopathy, and after thorough examination, we found no skeletal abnormalities. And the ultrasound revealed that he has hepatosplenomegaly with normal gallbladder and biliary tract. Of course, we did CBC with differential, and it showed that hemoglobin levels was 6.7 gram per deciliter with low hematocrit and normocytic normochromic. Platelet count was within the normal range, and total leukocytic count was slightly elevated with normal differential count. Peripheral blood smear showed that the patient has the marked normocytic normochromic anemia with anisopoikilocytosis, and occasional normoblasts were seen. Actually, there was no abnormal morphological features regarding myeloid or erythroid lineage. We also ordered chemistry, and it revealed that the total bilirubin was 4.7 milligram per deciliter, and LDH was elevated. It was 200 unit per liter, and the iron profile showed that the serum iron was 189 microgram per deciliter, and the ferritin was high. It was 600 nanogram per milliliter. ESR was a little bit slightly higher. It's normal. So hemolytic profile was then ordered by the clinician because they were concerned about the dark coloration of urine, and it was all the hemolytic profile was completely normal, and viral screening was negative. So to summarize the case so far, the patient has pallor, jaundice, hepatosplenomegaly, enlarged lymphadenopathy, and positive family history. And the reticulocytic count was 2.7% after the blood transfusion. He has normocytic normochromic anemia, high ferritin level, and high indirect bilirubin. Also, the viral screening and hemolytic profile was normal. So to proceed further with this patient, we developed an algorithm based on the reticulocytic count. So in our case, when the reticulocytic count is low or normal or slightly elevated, we look for the iron profile of this patient, and as we discussed before, that the serum iron and the ferritin was elevated. So we moved forward by doing bone marrow examination and iron stain. So the bone marrow picture revealed that this is high power, showing erythroid hyperplasia and prominent. Yeah, this one is not clear, so have a closer look here. There's erythroid hyperplasia with binucleate forms, and there's an evidence of this erythropoietic changes in the form of binucleate forms. Also, this picture showed that there's a few megaloblastoid changes here. I don't know. This one is working. Few megaloblastoid changes together with the binucleate forms. So the bone marrow aspirate report was released and showed that this is a markedly hypercellular marrow with normal megakaryocytic lineage. Myeloid series was relatively depressed, and erythroid series showed marked erythroid hyperplasia, this erythropoietic forms, few megaloblastoid changes, and the binucleated forms account more than 10% of erythroid lineage, especially in the late and intermediate normoblasts. Also, there was no abnormal malignant cells could be encountered in the bone marrow smear. Fortunately, we did also bone marrow biopsy for this patient because it was ordered by the clinicians. And as we see here, that this is the markedly hypercellular bone marrow with normal topography. now? 4 years. But there's no high normal, yes. And with the high power, we can see that there's only erythroid lineage here, so that means that there is erythroid hyperplasia, and mainly this erythropoietic forms mainly with binucleate forms. This is another picture showing binucleate cells. We also did reticuline stain, and it showed that there was mild reticuline fibrosis. Also, the iron stain was done and showed increased iron stores with no pathological or ring sideroblasts. Bone marrow biopsy report was exactly the same as the bone marrow aspirate. There was no controversy between them. And so the conclusion is hypercellular bone marrow with marked erythroid hyperplasia, and the erythropoietic changes suggestive of CDA type 2. We also investigated his older brother. He had the same anemic manifestations, and we did bone marrow aspirate, and actually it's the erythropoietic changes were more prominent, and binucleate forms and multinucleate forms were more prominent here, more frequent in the film. This is another picture showing multinucleated cells. And this one is multinucleated. Yes? This is multinucleated, right? Oh. Okay. And bone marrow biopsy was done, and it was the same picture as his brother, with marked erythroid hyperplasia, multinucleated cells and binucleate cells. So diagnostic criteria of CDA should be done when we fulfill all the A criteria and at least one of the B criterion. A criteria comprise the evidence of congenital anemia, jaundice, and evidence of ineffective erythropoiesis, and finally typical morphological appearances of bone marrow erythroblasts with at least 10% of binucleate red cell precursors. And regarding the B criteria, Ham's test was done for this patient, but outside Abu Rish Hospital, and it was positive. Also, electrophoresis could show that there's abnormality of band 3 and band 4.5, and if we have electron microscopy, we could see that by electron microscopy there's double membrane running internally under the cell membrane of the late erythroblast, which is due to accumulation of protein vesicles. So the case summary here that the mother was diagnosed as CDA with anemic manifestations. She was diagnosed as CDA type 2, but outside the hospital, and the father was clinically free, and both children suffer from CDA type 2. So as we know, CDA type 2 is an autosomal recessive disorder, and for a phenotype to manifest, it requires 2 copies of causal variants in both chromosomes to occur. So we suggested that the mode of inheritance in our case could be attributed to pseudodominance, which is a condition where the recessive allele mimics the pattern of a dominant allele. An example for pseudodominance, when you have an homologous pair of chromosome, one allele is deleted, the normal allele. When the normal allele is deleted, the other allele, the recessive allele, will pronounce and will be expressed, and the patient suffer from the disease. So in our case, we have a mother who is, we didn't do the genetic testing, but we just a speculation, yes. So we have a mother homozygous for an autosomal recessive disorder, and the father is maybe heterozygous for the same disorder, so the children may have a 50% chance of being affected. To sum it up, congenital dyserythropoietic anemia is a heterogeneous group of inherited disorders of erythropoiesis, which is characterized by anemia, ineffective erythropoiesis, and dyserythropoiesis. We don't have time to discuss the different types of CDA. And finally, the most serious complication of CDA type 2 is the iron overload, which causes secondary hemochromatosis and multiple organ affection like arthropathy, diabetes mellitus, cardiomyopathy, and graft rejection in case of stem cell transplantation. And if the patient is on regular transfusion, so iron chelation is a must. Thank you so much.
Thank you, Dr. Alaa, for a nice presentation.